In the space of 1 year, the Central African Republic has spiraled into uncontrollable violence. Attacks have claimed the lives of civilians and humanitarian workers alike. Security incidents affecting MSF have become increasingly frequent and increasingly serious. On the 26th of April 2014, an attack on Bugila Hospital left 18 people dead, including 3 MSF staff. MSF was working in the Central African Republic long before the crisis began, in 2 towns in the west of the country, Pawa and Kano. In August 2013, a new program was launched in Bria in the east, providing medical care for people who had been living in the bush, having fled their homes to escape abuses by the Seleka, the rebel coalition in power at that time. No health facility was operating in this part of the country, and malaria was wreaking havoc.
When we were in the bush, we couldn't do anything when the children fell sick. To care for them, we used roots and leaves from the trees as medicine. There was no hospital in the bush, and even the treatment we used didn't work for the children.
On the 5th of December, the situation took a major turn when anti-Balaka forces attacked Bongi. That day, MSF's team pre-positioned at the community hospital saw more than 100 casualties. The atrocities have continued ever since, and the teams have now carried out more than 2,000 surgical procedures in Bongi, mainly on victims of violence. At the end of February, after some rehabilitation work, MSF moved into new facilities, bigger and better adapted. Since the move to the General Hospital, patient care has improved. Meanwhile, the violence has spread across the country, forcing MSF to launch new emergency activities in Bongi and in the west.
The other activity we're running in Bongi is at the Mamadou Mbaiki Health Center in PK5, one of Bongi's Muslim neighborhoods. And we're also doing medical consultations at the main mosque where 1,000 or so Muslims and Fulani are gathered. The other emergency project is Bokuranga that opened a few weeks ago. We're working at the inpatients department and doing pediatric consultations at Bokuranga Hospital. And we're also supporting 11 peripheral health centers. We're at a crossroads here between several countries, Cameroon and Chad. There are quite a few armed groups around, and there's also the transhumance of the Fulani, which generally causes tension and conflict. So we'll definitely be staying until September or October to see how the security situation develops and make sure people get access to care during the peak in malaria.
Areas that managed to stay peaceful quite some time have since been caught up in the violence, including Kano, which has been in the hands of the anti-Balaka since the beginning of February. Fighting in the town and surrounding areas has caused large numbers of casualties who can't get proper treatment in the town's hospital. MSF referred the most severe cases to its other surgical projects, despite the difficulties involved in evacuating Muslims targeted by anti-Balaka militia. At the beginning of March, a mobile emergency surgical team arrived from Bongi to help cope with the inflow of casualties. The violence has forced large numbers of Muslims and Fulani to take refuge in the Kano church. Despite the latrines, showers and medical consultations provided by MSF, the conditions are very difficult. The 1,000 or so people living here are waiting for a chance to leave Kar, or at least get to the east or north of the country. According to the UN, in mid-March 2014, there were 600,000 displaced people in the country and almost 300,000 refugees in Chad, Cameroon, Congo-Brazzaville and the DRC. Although the whole of the Central African population is suffering from atrocities committed by both sides, the Muslim community is particularly targeted, and people are condemned to live in enclaves until they're able to escape. In Chad, MSF is working on 3 sites with large concentrations of refugees, providing medical care and managing supplies and sanitation facilities. They hear the same stories of flight, panic and violence.
Tout d'abord, il y a l'attaque de leur village, l'attaque de leur campement. Et là, c'est la fuite, l'éparpillement.
First, there were the attacks on their village, on their camp. And people started to flee to the bush, scattering this way and that. Then came a second stage, in which they usually tried to get to the capital, Bongi, where the Chadian army was organizing convoys to take people, in theory free of charge, to Chad and the surrounding countries. And there again, their flight was marked by violence, with stories of rape. And when they arrived, they found that not all their family had made it. Some members were lost along the way.
When the trucks arrived, everyone rushed to get on. There were lots of trucks. They were crammed full. There were so many people that the children couldn't breathe. The driver stopped to see what was wrong. We told him that the children were crying because of the heat.
Here, the refugees are safe, but their living conditions are difficult. Many of them are living in the open or in makeshift shelters. The water supply is insufficient and there are not enough latrines, and food distributions are irregular. Some live in hope of returning home, but the reports of massacres on the other side of the border are making this an ever more distant prospect.
In July 2013, in the wake of a wave of violence that had hit the region of Kamengo in North Kivu, 4 members of MSF, Chantal, Philippe, Richard and Romy, went in to assess the population's health needs.
Le 11 juillet, à partir de 10 heures le matin, on n'a plus eu de contact téléphonique ou autre.
Since 10 o'clock in the morning on 11th July, we have had no telephone contact or any other form of contact with this team. And unfortunately, it's now the 17th of May, and we still have no direct news from these colleagues or direct proof of life. It's no secret that this zone was under the control of a group of Ugandan rebels at the time, and we have information indicating that this group is behind the disappearance of our colleagues.
Et derrière la disparition de nos collègues. On a des preuves de vie indirectes via des prisonniers de guerre.
We've had indirect proof of life from prisoners of war or former hostages who have told us that our colleagues are still alive. In any case, from day one, we have had a crisis team unit up and running in the field and head office. This crisis unit, is doing everything in its power to find them and bring them home to their families.
Le mieux possible pour tenter de trouver les collègues et organiser le retour auprès des familles.
Several hundred people are thought to be being held hostage in North Kivu today. The Congolese army has regained control of a number of areas formerly in the hands of the rebel group ADF NALU, but MSF is concerned about the fate of its colleagues and all those being held by this group, and is asking for precautions to be taken to preserve the lives of the hostages. The same violence that led to the disappearance of our 4 MSF employees forced thousands of people to seek refuge in Uganda. The Bubukwanga transit camp rapidly became full, and the refugees were gradually transferred to a permanent camp. MSF brought assistance to more than 50,000 people, Congolese and Ugandan, improving health conditions, treating malnutrition and vaccinating the refugees.
We're having to share plastic sheeting. There are no rooms, no roof. And with all these kids, it's a real problem. And when it rains, we spend the whole night in water.
Back to the DRC. On both sides of the border, the view is the same. Thousands of people living in tents. This time we are a bit further south in the region of Goma. Presence of the rebel group, the M23s, has triggered large-scale displacements of the population.
There are currently 15 to 20,000 people living in Mugunga 3 camp. Half of them were already there last year, and the rest arrived after the M23 rebels took Goma in December. They fled from the camps north of Goma, where they had been living, to Mugunga, and set up there.
The number of refugees living here depends on the amount of fighting in the region. The population is constantly on the move to escape the violence and is followed by MSF's teams, who provide medical care to limit the effects on health caused by the terrible living conditions. In Mugunga 3 camp, like on the other projects elsewhere in the DRC, MSF is working hard to prevent epidemics of measles, malaria and cholera.
We're running an outpatient clinic where we're able to give consultations and treat patients before hospital referral. And we do a lot of work with victims of sexual violence. There are a lot of negative elements, armed militia, or it can even be soldiers from the Congolese army, who hang around and take advantage of the situation. So it's a really big part of what we're doing, this work with women who have been raped.
The violence has been going on for years in the east of the DRC, perpetrated by the large number of militia, but also by members of the regular army who don't hesitate to carry out atrocities, reprisals and pillaging. The mandate of the UN force MONUSCO has been strengthened, but so far has not managed to end this vicious circle.
This is Bor in January 2014. This is Malakal a month later. These pictures illustrate the violence raging in South Sudan since the end of 2013, when the fighting between government and opposition forces first began. A struggle for power that started in the capital and spread rapidly across the country. Thousands of people have died. 300,000 others have decided to flee the violence and deprivation and are seeking refuge in the neighboring countries. Their main destination is Uganda. The South Sudanese began crossing their country's southern border in December. In January, MSF began deploying emergency assistance in the camps and the nearby Zaipi hospital.
The situation was very chaotic, and we have put in place immediately water tanks to provide water, and we have also put in place an outpatient consultation which was addressing the urgent needs of the population. In the health center where we are involved, we scaled up the capacity for the inpatient department. So basically, we increased the capacity in the delivery room and in the maternity. We have implemented intensive feeding program for the malnourished children, and we have provided staff.
In May 2014, about 70,000 refugees were living in the district of Adjumani. When they first arrive in Umanzi transit camp, the MSF teams offer them a medical consultation, give them routine vaccinations, and screen the young children for malnutrition. And this care continues in the 4 permanent camps. Between January and the end of April, the teams carried out 37,000 medical consultations, mainly for malaria and respiratory infections. Their other destination is Ethiopia, on the eastern border with South Sudan. After days and sometimes weeks of walking, the refugees arrive in the region of Gambela. Like in Uganda, MSF starts caring for the refugees as soon as they arrive in the country.
The majority of the arrivals are mainly women and children. I think it accounts for about 90% of the number. These people, due to the long distances they have to walk, they arrive basically in a fatigue state and very tired.
At least 110,000 South Sudanese were living in Ethiopia in May 2014. In the camps in the Gambela region, the living conditions are extremely difficult. There are not enough shelters or latrines, and water and food are in short supply. MSF is working in 2 hospitals, in Lecho and Itang, managing outpatient consultations, maternity services, and rampant malnutrition. In Lecho, the screening of children under 5 carried out in May showed that 1 in every 20 children is suffering from severe acute malnutrition. There are many cases of severe diarrhea, respiratory infections, and measles, diseases related to living conditions.
Water supply is still at the acute phase, is still below the acceptable standards. And the issue of shelter, now with the rains coming and possibly malaria season will start soon. So the shelter issues are still a major problem.
In 3 months, MSF teams in Ethiopia conducted 12,300 medical consultations. But this is still not enough to meet the needs. This crisis calls for mobilization on an exceptional scale and simplified procedures for the deployment of aid. At the end of May, with 1,000 South Sudanese crossing the border every day, the humanitarian response was largely insufficient, and heavy rains were already flooding the refugee camps.
March 2011, the start of the Syrian conflict. Today, with the death toll already standing at 160,000, there is no end in sight. The army continues to drop barrel bombs on towns. In August 2013, an unprecedented chemical weapons attack in the Ghouta Valley killed 300 people. In the north of the country where MSF teams are based, the security situation has deteriorated considerably.
Le 2 janvier dernier, 5 collègues de centre opérationnel de Bruxelles avaient été
On the 2nd of January 2014, 5 colleagues from the Operational Center of Brussels were arrested, so to speak, by an armed group in the north of Syria. These colleagues were held in northeast Syria in very difficult conditions for several months by this same armed group. They were freed in May of this year. This kidnapping didn't end badly, but MSF feels that we still don't have the security guarantees we need to carry out relief operations in some parts of Syria, even though the needs are huge.
Dans certaines zones de la Syrie, même si les besoins sont énormes.
Security problems have already forced MSF to close some of its bases in northern Syria. Another hospital opened in the governorate of Aleppo in the spring of 2013 will soon cease operations too. It has been providing care for the indirect victims of this conflict, a population overlooked by the handful of other medical aid providers present in the area.
On va partir de certaines zones, mais on partira pas de la Syrie.
We're going to leave some areas, but we're not leaving Syria. We'll try and strengthen our contacts with all the commanders, all the Islamic theological leaders. We must maintain dialogue, explain what MSF is about. And if we do manage to get security guarantees from certain armed groups, we'll probably review the decision. We'll probably go back into some of the areas we've pulled out of in a significant way.
D'une façon importante dans certaines zones abandonnées par MSF.
The hospital in the Idlib area is still running. It opened in June 2012. At the time, the fighting was just a few miles away. The front line has since moved off and the hospital is seeing fewer casualties. But the poor living conditions cause many accidents and treating burns has become the hospital's principal activity. These patients also receive physiotherapy treatment and psychological support is available to anyone who needs it. Thanks to a network of Syrian volunteers, MSF has also been able to distribute tents and medicines to the displaced people forced to flee the region of Al-Safira in October 2013.
And they all left because over a period of 5 days, the whole area was bombed very heavily. So the camps full of IDPs plus the city of As-Safira itself was under heavy bombardment for 5 days. And pretty much every member of the population had to leave, those that weren't injured.
The situation is getting worse by the day and more Syrians are fleeing their homes. According to the UN, there are now 6.5 million displaced people in Syria and 2.7 million refugees in the neighbouring countries. They are living in camps or with host families and depend on external aid to survive. In Iraqi Kurdistan, MSF is working in 2 camps in the province of Erbil, providing outpatient consultations, emergency treatment and mental health care. In Jordan, the injured needing surgery and physiotherapy are transferred to the Amman program, which also runs an outpatients clinic for refugees. Between March and November 2013, the teams ran inpatient and outpatient services for children living in Zaatari camp. These activities were suspended at the end of the year as health needs were well enough covered by other humanitarian aid operators. At the same time, a clinic for women and children opened in Irbid, where teams are providing medical care for refugees living with host families or Jordanian families without access to the country's health system.
The typhoon that hit the Philippines on the 8th of November 2013 was of an unprecedented intensity. Although well prepared for this kind of event, the extreme violence of the disaster took the population by surprise. The storm surge and the winds, reaching 235 miles per hour, completely destroyed the coastal villages. According to the Filipino authorities, 6,200 people lost their lives.
The landscape was apocalyptic. It was day 6 after the typhoon. There were huge amounts of debris everywhere. The main roads were open, but the buildings were very, very badly damaged. Everything was destroyed. Lots of places were reduced to rubble, and there was quite a lot of places where the stench of death was pretty strong.
For MSF, the first problem was getting to Tacloban, one of the towns worst affected by the typhoon. The airport had been destroyed, and aid was having trouble getting through to the people who needed it.
On savait que l'aéroport avait été touché, que les voies de communication étaient complètement endommagées.
We knew that the airport had been hit and that the roads were completely impassable. The team had to wait 5 days before it could get through. So the first thing we had to do was figure out how to get there. The army made it through first and started clearing operations. So we started looking for private means of transport to take us there.
Where the teams were based, only 2 of the 15 hospitals were still providing partial services. As soon as MSF's tent hospital reached Tacloban, 10 days after the typhoon, the team set it up and immediately began providing surgery, emergency treatment, inpatient care, outpatient consultations, maternity services and neonatal care. At the same time, 2 dispensaries were set up in villages to the south of Tacloban.
Here we're in Tanouan, about 30 minutes from Tacloban. Over there we're setting up an inflatable tent hospital to provide maternity and pediatric services in an outpatient unit.
Between the 8th of November and the end of December, MSF carried out 260 surgical operations, more than 15,000 consultations, and delivered 130 babies. 3,000 families received essential items such as tents, kitchen utensils, and blankets. Once the emergency phase was over, the Filipino public services began to get back on their feet.
From what we can see, things are moving very fast. We didn't think it would be so quick. So we imagine, or we hope at least, that in a few months' time, public services will be running normally again.
At the end of May 2014, MSF's teams were still on site, focusing on women's and children's health. They will stay until medical services are fully restored and coping with the needs.
She's been on a box.
Located near the Cité Soleil slum area in Port-au-Prince, the container-based Rwanda Hospital opened in 2011. After the inflatable tent hospital set up to care for the victims of the earthquake in 2010, with health needs still huge, MSF wanted to continue working in the country. In just 1 year, the teams dealt with 13,000 surgical emergencies here. The focus has been on providing care for victims of violence, including sexual violence and road or domestic accidents. The hospital is also the country's only referral centre for major burn injuries. This type of treatment is expensive, and despite the extensive needs, it is not a high priority for the health ministry in this country where living conditions are still very difficult. There's never an empty bed in Drouillard's burns unit. 1,400 patients were treated here in 2013.
Most of our patients are children, between 1 and 2, the age they start walking and exploring the world. They often burn themselves with hot food. The burns are relatively superficial, they heal quickly, but there are lots of patients, so this activity takes up most of our time. On top of that, we've also got patients, usually adults, who've had more serious accidents, flame burns or electrical burns, because the power network in Haiti is in a pretty bad state. So these are the patients with the most serious burns, who have to stay in hospital longest. They're more complicated burns to treat, with quite a high mortality rate.
Clausel has to do several jobs to earn a living. When he's not a builder, he's a carpenter, plumber or electrician. When this interview took place at the beginning of September, he had already spent a month in hospital. He has burns to his elbow and ankle.
There's a private transformer in my neighbourhood. Usually, I do the maintenance. There was a problem. I went to see what was wrong. A cable had been cut, a high voltage cable. That's how I got burned.
Drouillard Hospital also has a trauma unit. Road accidents, gunshot and knife wounds are the main causes of admission. Today, 3 surgeons are operating on a patient with an open fracture after a road accident.
We've just performed a procedure using a fairly multidisciplinary approach. The team included the orthopaedist, because it's an infected compound fracture, the plastic surgeon, and myself, the vascular surgeon. It was a complicated procedure. The 3 of us worked together in good conditions. Without this intervention, this young woman would have had to have her leg amputated.
Whether victims of burns, road accidents or violence, patients generally need physiotherapy.
Cada serviço tem a sua peculiaridade. Por exemplo, serviço de queimados aqui no Haiti.
It's different for each unit. For example, in the burns unit, the patients need preventive physiotherapy to stop their skin from contracting, and also functional physiotherapy.
A nível funcional também. Então, o serviço já de som intensivo, serviço
Patients from the intensive care unit come for respiratory physiotherapy. And in outpatients, we offer rehabilitation care so the patients can get back into society.
E aqui no serviço ambulatório já é serviço de reabilitação para a reintegração do paciente à sociedade.
Today, MSF's objective is to concentrate on major burn injuries. A new hospital, easier to reach and devoted entirely to the treatment of burns, will soon be opening its doors in Port-au-Prince. Meanwhile, discussions are underway with the Haitian health authorities that will enable MSF to determine precise needs for traumatology and what specialities lack suitable facilities. If the needs are confirmed, the teams will resume their traumatology activities.
Gaza Strip, autumn 2013. Trapped by the Israeli blockade, the population here saw their living conditions deteriorate even further when the border crossing into Egypt was closed as a result of the political crisis unfolding in the next-door country. This border closure has deepened Gaza's economic crisis. One consequence, people are using old bottles of gas, causing an increase in domestic accidents and large numbers of casualties, like this young boy.
And ask the patient if he complains of any pain and في وجع عندك? No.
The patients are all operated on a number of times over the year. They're mostly children with burns and sometimes other injuries. And there are also domestic accidents caused by the embargo and because of generators blowing up. We want to reduce the waiting list. At the moment, there are more than 450 patients waiting to be operated on in the Gaza Strip.
In 2013, almost 300 patients underwent surgery at the Nasser hospital, specialized in hand surgery. These patients then continue treatment at the post-operative care clinic.
What we're aiming for with this post-operative care is for patients to get all the mobility back in their limbs and be able to do day-to-day activities again.
Still in the Palestinian territories, this time the West Bank, here MSF is working with people with post-traumatic disorders or suffering from acute stress. More than 2/3 of the territory is under Israeli military control. This everyday violence is heightened by the presence of more than 500,000 Israeli settlers. In Salem, as in many other villages, the inhabitants have no choice but to live alongside the settlers. Wissam comes here regularly to give consultations.
Like every village in Palestine, Salem had a lot of suffering. First of all, there is a non-Moree settlement beside them, and the settlers used to come down and to harass the people. Also, the soldiers of the Israeli army, they used to enter the houses and to arrest the people.
The psychologist continues her rounds. At each stop, she is witness to the disastrous consequences of this forced cohabitation. People living in constant fear, their olive trees just a few feet away, burnt to the ground.
The team at Grozny's Republican Emergency Hospital is getting ready. In a few minutes, these people are going to carry out a cardiac catheterization and angioplasty. We're in the cardiology department's intensive care unit. It's the end of a 2-week workshop. MSF's doctors have been training the hospital staff.
La coronarographie, c'est une technique médicale en fait.
Catheterization is a medical technique used to visualize the inside of blood vessels. So for a cardiac catheterization, for example, that means the coronary arteries, the arteries of the heart. It's usually performed as part of what we call an angioplasty, a procedure during which a tiny balloon is positioned in the narrowing of an artery, forcing it to widen.
L'équipe tchétchène sur Grozny avait débuté.
The Chechnyan team in Grozny had started doing this kind of intervention. As they're not at the same level, our role is to provide some very specialized outside expertise, which will, we hope, very rapidly improve the quality of catheterization and angioplasty care.
Des soins qui sont à faire au niveau coronaro et au niveau angioplastie.
This training program is new. It is part of a cooperation project between Grozny Hospital and MSF that began at the end of 2010. The aim is to improve the quality of care in this country where 1 person in 6 suffers from cardiovascular disease. These pathologies are responsible for approximately 2/3 of deaths.
There are well-known risk factors. The risk factors that are not modifiable, that we can't do much about, are age and sex, of course. But out of all the other risk factors that are modifiable, the main one is smoking. Then there's obesity, which goes hand in hand with a sedentary lifestyle. And there are also the major diseases like hypertension and diabetes. These risk factors are found in this country in the same way as in France or North America. But for me, the big difference is in the screening, prevention, and treatment of modifiable risks.
MSF's intervention has led to new techniques being introduced, such as fibrinolysis, which breaks down blood clots, as well as improvements to the supply of drugs and medical material, to the monitoring of people suffering from coronary disease, and to staff training. For Zara, this program, this intervention, has quite simply saved her life. She is bringing up her 2 grandchildren on her own on €100 a month, and there is nothing left over to pay for the medical care that she needs. In 2013, a total of 830 patients were admitted to the intensive care unit. 500 of them were suffering from an acute coronary syndrome. The care and training will continue throughout 2014. The objective is to improve the diagnosis and provide people with acute coronary syndrome with more rapid care to reduce the risks of mortality or complications, and allow these patients too to return home.
For more than half a century, antibiotics have been an easy means of treating infections that were once fatal. But today, doctors are faced with an increasingly worrying situation. Their drugs are no longer working. Their patients are back in danger.
Les principales causes de développement des résistances aux antibiotiques sont d'une part.
The main reasons for the development of resistance to antibiotics are their overuse for fevers, not due to bacterial infections, the use of counterfeit antibiotics, and poor prevention of infections, especially in hospitals, and also factory farms administering antibiotics to farm animals to promote growth.
Le fait que les antibiotiques soient utilisés depuis des années dans l'industrie d'élevage comme facteur de croissance.
And lastly, the mobility of populations, especially in the conflict zones where we work. Populations that move from one country to another spread this phenomenon.
There is nothing new about this observation, but in 2014, for the first time, the WHO published a report on the subject. It confirms what MSF teams were already faced with on programs such as the surgical program in Oman. Here, MSF treats people who have been injured in other countries in the region, especially Iraq. In 3/4 of these patients, the doctors see infections due to resistant bacteria. It's the same problem in Haiti, on the burns program, or in the Central African Republic. Here, the doctors were trying to treat 5 people whose infected wounds were not healing with the usual treatment.
This is expensive for MSF because it increases the cost of operations, mainly because we have to bring latest generation antibiotics into countries that don't have them. They're often hard to import, and the treatment is longer and more costly. And also because we sometimes have to close hospitals to decontaminate and disinfect them from top to bottom. For our patients, resistance to antibiotics means treatment failure. This treatment failure can take a number of forms, including amputation if someone has an infected leg that won't heal, or increased mortality in some populations, especially in patients with HIV infection or who suffer from malnutrition.
The publication of the WHO report is an opportunity for MSF to echo the warning it contains and demand better surveillance of resistance to antibiotics, which at the moment is a poorly documented phenomenon. Containing this phenomenon will require international level coordination and considerable investment in research. But there are measures that can be put in place immediately, restricting the prescription of antibiotics to trained practitioners, fighting counterfeiting, and ensuring more stringent application of hygiene and sterilization rules. MSF doctors regularly treat burns and bone infections. Without such measures, and without a new generation of antibiotics, they will have to abandon these programs.
Chiradzulu District, Malawi, in 2001.
Why introduce antiretroviral therapy? Because our doctors are dealing with opportunistic diseases. Our patients come back time and time again, and we end up burying all of them. Everybody has the right to health care, and that's why, in the right conditions, we want to introduce antiretrovirals to Malawi. We want to be able to treat patients.
Chiradzulu again, this time in 2013. For the last 12 years, people with HIV and treated by MSF have had access to antiretrovirals. Epicentre, a centre for epidemiological research, and MSF decided to conduct a survey to evaluate the HIV transmission rate and people's access to treatment.
The survey has shown us that it's possible in areas in sub-Saharan Africa with very high prevalence to have a substantial proportion of the population living with HIV, close to 80%, who are on treatment and in good health.
During this survey, the teams used incidence tests that measure the rate at which the epidemic is spreading within the population.
Incidence means the number of new cases in a given period. There are new tests that have just come out and that are still in development. And MSF, through its epidemiology research centre Epicentre, wants to participate in this development and is trying, for the first time, to quantify transmission. Has transmission decreased, or is it still at a peak?
The first surprise was obviously the rate of HIV transmission. It was much lower than we anticipated. This shows that the epidemic is in the process of being controlled in Malawi's Chiradzulu district.
Probably due to the broad antiretroviral therapy coverage and the quality of the monitoring of patients on treatment. The effectiveness of this treatment means that people who are HIV positive have only a low presence of the virus in their blood, so there is very little chance of them transmitting it. Another survey conducted in Kenya in 2013 showed the epidemic still to be active with a very high transmission rate. In the sub-district of Ndiwa, 1 person in 4 is infected by HIV.
Which is why we decided to take action that, for the first time, would be aimed at bringing this incidence rate down. In other words, we would be attacking the epidemic itself, not just treating the patients with HIV and AIDS, but doing both.
To achieve this, the teams need to reduce mother-to-child transmission and improve the quality of care.
We're also going to put a number of innovative interventions in place. For example, we're going to try and make sure that all the children, all the babies are screened during their immunization vaccines at 6 weeks and 9 months.
Today, MSF's objective is to hand over to the health authorities HIV projects that work well, like the one in Homa Bay in Kenya or Arua in Uganda. In Malawi, staff shortages are making the task that much harder. The teams are trying to simplify and decentralize patient management by spacing out medical consultations, for example, and introducing viral load testing in the health centers. The Samba test, the first that can be used in a rural environment, shows whether or not the treatment of an HIV-positive patient is working. Previously, viral load testing could only be carried out in certain regional laboratories.
In Shirazulu, people live far away from the district hospital, and this is really an asset to be able to measure their biological viral load at the same place where they come to receive care. So the closest we can be to the patients, and the closest the laboratory can be to the patients, the easiest it is for the patient.
After 15 years of fighting AIDS, MSF is now focusing on the regions and populations neglected by international aid programs and by the states themselves, such as children and teenagers. The teams are carrying out exploratory missions to identify populations without access to appropriate care and decide what assistance they can bring them.
For MSF, managing tuberculosis is a priority. It's currently working on TB programs in 16 different countries. In 2013, teams diagnosed more than 4,800 people suffering from the disease. Yet for years, our field teams who are working with outdated, ineffective and ill-adapted tools have been waiting for innovations, notably in Armenia, where many people suffer from a resistant form of the disease.
For those who are failing the MDR treatment, in fact, in Armenia before 2013, there was no treatment options. It means that a patient fail and end up in the street or in a palliative care center or at home and waiting for dying.
This is bedaquiline.
For these patients, a new drug, bedaquiline, brings new hope. The clinical trials have not yet been completed, but compassionate use is already authorized for patients suffering from resistant tuberculosis, and for all those for whom other treatments have failed. 50 or so Armenian patients treated by MSF are receiving a series of antibiotics that includes bedaquiline. 1 year after starting the first patient on this treatment, initial results are encouraging. Virtually all the patients are showing signs of improvement, and side effects appear to be limited.
With bedaquiline, we use other drugs which are new for TB in Armenia, and that is why it demands to be more prudent with side effect monitoring. And the main side effect is the changes in electrocardiogram. We follow it very accurately. We do ECG every week. At this moment, in my practice, I didn't have the case when the patients complained from bedaquiline side effect.
MSF is also fighting tuberculosis in Cambodia. Here the issues are very different. What worries the teams is the high percentage of the population suffering from the disease. Cambodia is one of 22 countries with the highest prevalence. The challenge is not so much with using new drugs, but diagnosing the disease and getting patients on treatment.
Big majority of the TB patients, people with
active TB inside, they are not identified by the existing system. And the existing system reaches its limit. So now we need to find new mechanism, new system, to identify all these persons, all these patients who have an active TB, but who are no symptom, who are not identified by the existing health system.
So the teams have started a pilot project for MSF, based on active case finding. They go into the communities looking for at-risk groups, such as people over 55, inform them about TB and the project, and encourage them to come to one of the screening centres set up by MSF, a means of ensuring that everyone who needs treatment gets it.
Summer 2013. The rainy season is in full swing in South Sudan. Yida refugee camp is flooded. For thousands of refugees living here, the risk of falling ill gets higher by the day.
The lessons learned from last year were that malaria, diarrhea, and acute respiratory infections were the main killers. So in order to prevent those diseases to spread in the camp this year, we launched a water and sanitation program, and at the moment we're doing a vaccination campaign to prevent mainly, but not only, respiratory tract infections.
The first vaccination campaign of its kind in an emergency setting. In just 3 months from July to September 2013, MSF vaccinated around 5,700 children under the age of 2 against pneumococcus and Haemophilus, the two bacteria responsible for the most severe types of pneumonia.
Well, this vaccination is special because this is the introduction of vaccination, a new vaccine or a new antigen in a population that is considered to be living in precarious conditions. This vaccine is not new. It has been introduced in several parts of the world. However, this is the first time, I believe, that in a refugee camp, in a situation like this, that we introduce such a vaccine.
It was important to be capable of introducing this vaccine in emergency situations, and this experience has shown that it is possible. But to generalize this type of campaign, we must be able to act fast, and this was not the case in South Sudan.
It has taken close to 9 months, I believe, for the entire process to materialize and for us to start giving the first dose of this vaccine. It took a few months to negotiate and to discuss with the authorities, the local health authorities. After that, there was discussions about the vaccine, acquiring the vaccine in itself. After that, there was a delay in terms of receiving the vaccine.
One of the difficulties with vaccination in emergency settings is keeping the vaccines at the right temperature until they are needed. To get around this problem, one solution is the so-called controlled temperature chain. In 2013, MSF, Epicentre, a centre for epidemiological research, and other partners carried out a study in Chad on a tetanus vaccine which was kept at 40 degrees for a period of 30 days. The conclusive findings give real incentive to devote more research to developing less temperature-sensitive vaccines. Vaccination in emergency settings is not the only challenge. An estimated 1 in 5 children worldwide still does not have access to all the vaccine doses needed before the age of 1. The obstacles may be logistical, but they are also financial.
10 years ago, we were able to vaccinate in routine immunization against 6 vaccine-preventable diseases, and it cost about $1.30. Today, we can vaccinate against a dozen or so vaccine-preventable diseases, but a full course of vaccines will cost about $40. We don't even know really what the real price of these vaccines are, because the pharmaceutical industry isn't very transparent about that.
This is a crucial issue for MSF. Teams dispensed some 1.5 million doses of vaccine across the world in 2013, more than half as part of routine immunization campaigns.
Programmed massacre of the Rwandan Tutsis began in early April 1994. 20 years later, our Doctors Without Borders are still looking for answers to the dilemmas raised by their mission in a country they watched plunge into horror. At the start of '94, an MSF team was already in Rwanda working with the thousands of people displaced by the conflict between RPF rebels and the government. A few days after the start of the genocide, a surgical team arrived in Kigali via an MSF and International Red Cross convoy that had set off from Bujumbura, the capital of Burundi.
The day after we arrived, we went with the ICRC, the International Committee of the Red Cross Medical Team, to visit Kigali's main hospital, the CHK, where we were supposed to be working. But with the ICRC medical coordinator, we saw straight away that it would be totally impossible for us to work in this hospital. They were killing the injured there, especially the injured Tutsi.
Only the field hospital set up in Kigali by MSF and the ICRC would be spared the massacres. Every day a team went into town to bring back the injured.
As we went through militia checkpoints, we were told that there was no point in us doing what we were doing, as they were planning to kill all the Tutsis anyway. So for each injured person, I tried to see whether it was worth making them run the risk of going back through the town and all the militia checkpoints. Otherwise, when the injuries were less serious, we treated people where we found them. We knew full well that their real problem was not getting treatment, but escaping from the militia who were out to kill them.
From the moment they arrived, the teams were witnesses to the unfurling of violence. But at that point, they couldn't know that what they were seeing was genocide.
Unfortunately, it took us a few days to realize there was absolutely no way people could go back to town after leaving the hospital without risking their lives, and to get organized by requisitioning neighboring houses so that we could keep the people we had treated, even if they were well enough to leave. So once we realized what was going on, we made some practical decisions like that. But the events were really overwhelming, and everything was happening so fast. It felt like we were running to keep pace and understand what was happening.
In just a few months, 800,000 people were killed. Some of MSF's staff also lost their lives in the murderous madness.
We lost at least 200 Rwandan colleagues just during the genocide. They were murdered. We were so aghast by the sheer scale of what was happening, how extreme it all was, that we, as an organization, didn't always do what we should have to help our colleagues get away.
In the face of a massacre on such an unprecedented scale and the difficulties it was experiencing bringing assistance to the victims, for the first time in its history, MSF called for an armed intervention. In an appeal stating that doctors can't stop genocide, it urged the UN to stop the killers and protect the survivors. Should we have spoken out earlier? Could we have done more to protect MSF staff? How should we have gone about treating casualties in the middle of this manhunt? 20 years later, the dilemmas raised by the Rwandan genocide are echoed in the Central African Republic and South Sudan, and our Doctors Without Borders are still seeking to resolve them.